Good morning. Thank you, Marco. We all know this grading system for predicting vascular invasion by tumor. I've seen this year some change by Rastopoulos, but the implant remained the same. What's important is radiologically that in grade 0, we have to see a fat plan or a pancreatic plan between a vessel and tumor. In grade 1, we cannot see this fat plan, and so the tumor and the vessel are contiguous. In grade 2 and grade 3, there are a little difference because we see indentation on the wall, on the vascular wall, and the difference between the grade 2 and grade 3 is the involvement of the perimeter of the vessel. In grade 4, obviously, we see constriction of the vessel. There is a little difference between venous vessel constriction and arterial vessel constriction. A venous vessel constriction could be venous invasion, vessel invasion, and arterial vessel constriction is always vessel invasion. But I want to show you our way of working with CT. What's important is that CT must be obtained before stenting the biliary duct, because we have to avoid artifacts of a stent and inflammatory changes due to stenting. Of course, we need multi-slice equipment. 16 slices are enough, 64 are better. Why? Because the vessel assessment, the vessel invasion assessment must be done with axial scans, but also with multiplanar reconstruction and volume rendering. So we need quick implants to avoid movement artifacts to obtain good multiplanar reconstruction. And the acquisition of the volume is very quick. It takes not more than a couple of minutes. And then we transfer our volume to our workstation. We know, a lot of time we know what we are looking for, so the way of working is guided. Personally, looking for a pancreatic carcinoma, I start with an overlook in a portal phase to see if there are liver metastases, distant metastases, looking for few effusion, perihepatic, perisplenic, or deep in pelvis that are the first sign of carcinosis. Then, following the enlargement of the biliary tract and the enlargement of Wirsung, we finally land on our tumor. It's very easy to reach the tumor. This is the tumor. It's close to the superior mesenteric vein. And then we can do something like this. We can rotate the tumor in this way. It takes a few seconds. And we can see that between this tumor and the vessel, I don't know if you can see, but there is a thin fat plan. If we go around the tumor and we rotate the tumor, we always see a fat plan, a thin fat plan. So the message in this case would be that this patient has no metastasis, has no carcinosis, has no enlarged nodes, lumboaortic nodes, and is a grade 0. I want to show you another case. Again, an overlooking portal phase. This is the overture studying pancreatic carcinoma. Again, this is an hemangioma, no problem, no liver metastasis, no effusion, no nodes enlarged, lumboaortic enlarged nodes. There is something strange along the mesenteric artery here, maybe a big hepatomesenteric trunk. We can confirm it. This would be an additional information to surgeons. It's very easy to obtain something like an angiographic view. Again, this is an arterial phase, you see. The arterial are emphasized in this phase. And this is the trunk. Again, we can rotate it. This is the ROI of interest. We can rotate only a moment. And this is what we can obtain is something like an angiographic phase. And we see here very well, this is a moment only, okay? This is the superior mesenteric artery. This is a big, very big hepato-mesenteric trunk. This is the celiac trunk with, we can rotate here again, with the gastric, left gastric artery, hepatic artery, and gastroduodenal artery, and a thin artery for left liver. But let's return. We were looking to pancreatic carcinoma. We know from ultrasound that there is a pancreatic carcinoma. We see again our hemangioma, and here is the cancer. Look, it seems to be a little cancer deep in pancreatic parenchyma. There is always a plan between the vessel, the superior mesenteric vein, and the cancer. So this seems to be grade 0. But the surprises are not finished in this patient because going down along mesenteric superior vein is a big collector, so it must increase its diameter going to the confluence with portal vein. We see a bulging here on the anterior wall of mesenteric vein. So we can try to look what is this bulging, what does it mean with an MPR reconstruction. And we see here that this bulging is an implant on the vessel. This is superior mesenteric vein. This is something like a lateral view, a lateral multiplanar reconstruction. This is superior mesenteric vein. This is the anterior wall of the superior mesenteric vein. You see there is here there is a bulging due to this implant. If we rotate, we can demonstrate it very well. So the message, if there is one implant, of course, we have to find other implants, and here is another implant, and another implant here. So this tumor that seems to be resectable has this complicance, and we have to sign it to our surgeons. And this is the second patient, and I want to finish with another patient, again, overlooking portal phase, to assess pancreatic, to assess liver parenchyma, no metastasis, enlargement of biliary duct, no ascites, neither deep in pelvis. That is a very important sign in non-hepatopathic patient, obviously. But what we see is, again, following the biliary tract, enlarged biliary tract, we land on the cancer, and we see here a big cancer involving superior mesenteric artery and superior mesenteric vein. Again, if we perform a multiplanar reconstruction, we can see that we cannot see the signal of superior mesenteric vein, and so we are sure that the superior mesenteric vein is completely involved. Also, this is a superior mesenteric artery, superior mesenteric vein. We see only enlarged, you see, enlarged mesenteric vein and enlarged mesenteric trunks that are signal of completely involvement of superior mesenteric vein. So this is grade 4 without any doubt. So we radiologists have no role in cases like this. We only can watch and see such as disasters. But you see, this is a wonderful MR image. Enlargement of a biliary duct, enlargement of Wirsung. Obviously, the cancer is here. This is the same scan, enlargement of biliary tract, enlargement of Wirsung, and here is a little cancer, grade 0. And then another case, you see here a big cancer all along superior mesenteric vein of the head of pancreas, but also here we can see a fat plan, a thin fat plan, so this could be a grade 0, grade 1, not more. And then this case is different. This is a grade 2, grade 3. You see indentation of the right wall of a superior mesenteric vein and portal vein. The fat plan is not always, we cannot see always the fat plan, so this is sure grade 2, grade 3. Again, enlargement of these trunks, mesenteric trunks. And the demonstration of the involvement of the confluence between one of those enlarged mesenteric trunks with superior mesenteric vein by tumor. You see here, this is a paraxial reconstruction. We see the involvement of the confluence with, between the mesenteric vein, superior mesenteric vein and the enlarged trunk, the cancer, and duodenum. And then here we have no problem. This is grade 4 without any doubt, the involvement of the confluence. And here again, this is a constriction of, from cancer of the portal vein, and complete, on the contrary, is completely cancelled the signal of superior mesenteric vein, grade 4, without any doubt again. And then I want to show this wall pancreatic cancer. Again, multiplanar reconstruction in arterial phase, and here we see the completely involvement of the celiac trunk. This is the left gastric artery, splenic artery, and common hepatic artery completely involved. So this is what we can do. 2 words about MR and also PET. MR is a wonderful tool in studying cystic tumors, but has no better performance than TAC in vascular invasion of pancreatic cancer. It has good performance looking for little benign lesions of liver in which CT is not excellent. Why this problem for MR? Principally because MR has not an excellent spatial resolution, and we know in these fields we work in fields where 1 or 2 millimeters are very, very important. 2 words about PET. PET is a good study looking for recurrence and after surgery. When there are a lot of inflammatory change after surgery, and so anatomic findings are not enough, and we must help ourselves with metabolic findings. But what I want to finish with this, the definition of resectability is evolving due, and we have seen it today, due to the chance to resect and substitute vessel. And what was once considered not resectable disease may now be resectable. What is very important for us radiologists is that the term resectable and not resectable should be used only when there is a clear understanding between the radiologist and the referring physician. So I want to finish. Our work is only to freeze the situation and try to explain it to our referring physician. Thank you for your attention.